Hello and welcome to this webcast, proudly brought to you by La Roche-Posay and Telios and coordinated by the International Dermoscopy Society. Thank you also for this opportunity to share some cases. Alex Chamberlain is my name. I'm a dermatologist from Melbourne, Australia, where I work at the Alfred Hospital. I'm also affiliated with Monash University. And I'm going to present a number of nail cases, specifically non-melanocytic examples. Let's start with this useful schematic, which is adapted from Dr. Jelinek's paper in Dermatologic Surgery in 2016, and I'll cover these three clinical presentations. Firstly, longitudinal melanonychia, or a pigmented band. Importantly, this is not always melanocytic in nature, so lentigo, nevus, or melanoma. Next, we have longitudinal erythronychia, or a pink or reddish band. And finally, xantholeucopachyonychia, so a yellowish, whitened, thickened band of nail. Here's our first case. This 60-year-old gentleman of Indian-Australian heritage presented with longitudinal melanonychia, at least that was his concern. We can see a slight distal notch involving the nail plate, and on dermoscopy, as well as the pigmented band, some splinter hemorrhage. On free edge dermoscopy, there's a keratotic mass, and the thin band is reassuring, in my opinion, as well as the keratotic mass. There's also a whitish component, I think, to this band, and I've tried to highlight the somewhat triangular lunula, which is also significant. This represents Onychopapilloma, and less than 10% of these benign lesions present with melanonychia. Typically, they present with longitudinal erythronychia, and the differential diagnosis might include SCC, lichen planus, or even Darier's disease. So let's discuss the diagnosis and significance of Onychopapilloma. As I've said, they typically present with longitudinal erythronychia, so a reddened band, but in our case presented with longitudinal melanonychia, which is seen in 10%. They're typically painless. 40% can be diagnosed using distal transverse nail clippings for histopathology, where you may see asymmetric hyperkeratosis, sometimes hemorrhage, as published in the JAD in 2016 by Tosti. More recently, multiple onychopapillomas have been noted as a feature of the BAP1 inactivated tumour predisposition syndrome, so something to look for when you see a patient with multiple BAPomas. Then finally, there are some newly reported signs associated with Onychopapilloma, specifically macrolunula or a trailing lunula, both seen in 20 to 30%, as per this publication in the JEADV 2022. In this case, we see a pigmented band that is broader distally, with irregular spikes and spears of onycholysis and some subungual hyperkeratosis. This nail also shows a localized dystrophy. It almost looks tented, and there's some hemorrhage laterally, seen better in the macro view. So a real mix of features. In this case, we cultured Trichophytum rubrum, so a dermatophyte, in keeping with fungal melanonychia. Other organisms that may produce a pigmented nail include Neoscididium, Candida, or Aspergillus, so not simply dermatophyte. Let's now think about the potential differential diagnosis for longitudinal erythronychia, so a pink or reddened band. And I again would like to acknowledge Dr. Jelinek's publication in Dermatologic Surgery in 2016. Most of the time, longitudinal erythronychia will represent an onychopapilloma. The other causes, I must admit, are rarities. Glomus tumours, which we see above in that example of a reddened band, these are typically painful. And a useful diagnostic test is Hildreth's test, where you inflate a blood pressure cuff to cause ischemia and the pain improves but then returns when the cuff is deflated. Both SCC in situ and amelanotic melanoma can cause erythronychia, and we see an example of amelanotic melanoma here down below. with a broad 5mm pink band and some localized dystrophy. So really you need to have a significant degree of suspicion to reach this diagnosis, or at least to proceed to a biopsy. And finally, if several nails are involved with erythronychia, you may be thinking lichen planus or Darier's disease, which will usually have crucial clinical signs elsewhere. Let's move on to Xantholeucopachyonychia, easier for the Greek scholars. Here's an example. This patient has an unusual localized nail dystrophy with yellowish thickening and expansion of the ventral plate with some onycholysis. And on the free edge dermoscopy, we can see these strange tubules or cavities within the localized thickening, and these are pathognomonic for the diagnosis and, in my opinion, somewhat reminiscent of honeycomb. Here's another example. These are both Onychomatricomas, which are benign fibroepithelial tumours of the nail matrix that forms tubules or tunneled cavities within the nail plate. Once seen, it's easily recalled. They present with an area of localized dystrophy with a thickened, overcurved, almost pseudo-clubbed nail plate. The free edge dermoscopic examination readily shows the tubular cavities. And there is a differential diagnosis, so-called Onychocytic matricoma, which is purely epithelial and a histopathologic diagnosis largely. This elderly male with a history of stage 3 scalp melanoma was noted to have this incidental thumbnail pigmentation, and whilst this initially looks band-like, we see on dermoscopy that the striations do not fully reach the cuticle. They're also somewhat yellowish, so xanthonychia. And on free edge examination, we see the pigment is very superficial and highlighting the topography of the aged nail, primarily the ridges. So this is Pseudomelanonychia, rather due to exogenous pigmentation, and in this case, this was nicotine staining, but you may see something like this from fake tan as well. This case also shows a nail dystrophy, really with some xanthonychia and some transverse striations, a pattern many of you will recognise. And I wanted to share this case because the UV dermoscopy beautifully enhances the topography of washboard nails with an almost pleated appearance. This pattern is also known as Habitic deformity from repeated manipulation of the proximal nail fold, be it from rubbing, picking or chewing, etc. Finally, let's look at a subungual hemorrhage. And whilst this is a frequent source of referral, it's not normally a diagnostic challenge. This young woman attended for another reason and dated this trauma to 8 weeks prior when she squashed her finger in her car door. And one can see her lacerated proximal nail fold with a curvy linear scar there. She also has varying shades of hemorrhage, so purplish, brown, and almost tan pigmentation, along with some bizarre shaped leukonychia, those very whitened shapes. And the main dermoscopic pattern we see in subungual hematoma is altered blood of varying shades, typically with a rounded proximal border, sometimes with globules from blood spill, and a capillary effect at the distal margin, which we can see in this case. Importantly, subungual hematoma doesn't rule out melanoma, so it's a good idea to follow these cases towards clearance. And that concludes my presentation, so I'd like to thank you for watching, and once again I'd like to thank our sponsors and Telios.